That's a great review, John. Thanks very much. And certainly a challenging situation. We did have there was a question that came up about telmisartan, but I don't know if there was a mistake with your presentation. I didn't catch that was an issue with this patient you presented.
No, not with this patient. Perhaps that question's kind of getting at the drug interactions with the DOACs, which fortunately are far less than with warfarin. I often joke that if warfarin were invented today, there's absolutely no way it would get drug approval if it was coming on top of the DOACs having already been around. It has so many food and drug interactions. Telmisartan, is that maybe a CYP? I know we have some pharmacists online. Is that maybe a CYP3A? I'm just mix up the CYP3A4 inhibitor or something. I think that's probably a mild interaction, if any. The main interactions that you have to worry about with the DOACs are the strong inhibitors or promoters of cytochrome P450 activity, the ketoconozoles, ritonavir, and those kind of drugs, rifampin, and carbamazepine. So not really very common drugs. And the ones where when you kind of yellow flag when you see that on your patient's drug list, this might be one to get the pharmacist to do a review of drug interactions. I guess I don't know any more than that.
I'm sorry, I don't believe it is one of the interactions. I know I have seen situations where the anti-seizure medications are an issue, and I have to talk to my neurology colleagues, but I think those are quite safe.
John, there's just a question about the dose of aspirin that's commonly used in combination with the DOACs.
Yeah. Oh, yeah. Good question. I think we still use the same old 81 milligrams once a day dose. As you probably know from the trials from 20 years ago plus, the antiplatelet response to ASA starts to plateau around 80 milligrams or so per day. So you're getting most of the effect that you get with that dose, and this is no different. I guess this is, if you're combining with DOACs, it's not the time that you want to make sure they're really getting the full-on antiplatelet action that you can get with 160 milligrams. So 81 milligrams is the answer.
So John, it's a real challenge. Obviously, the anticoagulation is important, and strokes are devastating, but that treatment is to prevent something that hasn't happened. Whereas our patient that you described has a proximal LAD stent. And I know my interventionalist colleagues, our colleagues, have quite a bit of angst about not using antiplatelets with those patients. So using the example you gave, the patient has a significant GI bleed and quite a drop in their hemoglobin. How soon, and so let's say they're scoped rapidly and things go well, are you going to hold the aspirin for a day or two? Or are you going to restart ticagrelor? What sort of timeline would you typically go with?
Yeah, gosh, Paul, honestly, your experience about this is probably as good or better than mine. That I'm going to refine my risk assessment of the need for the antiplatelet agent, the second antiplatelet agent, by listening to the interventionalist who can tell me whether did I put in 3 long stents at a bifurcation lesion, and I happen to know that one of the ends of the struts is kind of sticking out into the into the cross branch artery. They might know some, have a technical feel for whether this is a particularly high risk, and they we tried to get at that in the guidelines with identifying the so-called higher risk features. But those are, what do they call it? Level of evidence C, expert opinion only. There's not really good trial data on that. So when do you restart after a GI scope? I'm going to be talking to the gastroenterologist. Said, are you, pretty comfortable that this is this is under control now. Can we go back on? Because both with atrial fib and stent thrombosis, the risk can be actually fairly early when when you look at the people who are on anticoagulants who do have a stroke. It's often just during the few days when someone has stopped it. It doesn't take very long to raise the risk. It's not enormous. I'm not sure that it's a lot higher than the annualized rates of stroke that are calculated using the risk scores. So let's say your CHADS-2 score would suggest an 8% annual risk of stroke. Well, it may not be that the daily risk is 8 divided by 365. It might be that it's a little higher than that in that early period, but it's probably not 8% in those few days. It's a bit disappointing. You would think that we have so much data on this. You would think that a really clever clinical epidemiologist could have modeled this out for us pretty nicely. What exactly the risk is and what's the mathematical optimal timing for all of this. And in fact, the guidelines, while they did, get a bunch of smart people together to think this through, it wasn't like it was, mathematically precisely modeled what was the optimal timing and risk. It is just a balancing of risks and trying to find the most, the sort of safest navigation among the shoals for your patient.
It certainly seems like a situation where the telephone is a helpful tool. And like you say, speaking to the interventionalists, and there are, if it was 3 or 4 months, I might be much more confident. There are some interesting trials with not having the full year of dual antiplatelet therapy, but going down to just a single antiplatelet agent. But again, that first month is you picked a pretty tough case in that regard. And there was a surprising rebound. I know with the Rocket AF study, when we enrolled patients in that, and after the conclusion of the study, they counted strokes for the next 30 days and went from statistically significant benefit to losing that benefit because of the unexpected number of strokes in just that 30 days. So it really is an area where you need a lot of judgment, and there's not as much evidence to support these decisions. We tend to be cautious, but inactivity with an LAD stent presents risk, and obviously bleeding, ongoing bleeding presents real big risk as well.
It's interesting. I see way more frequently than I would expect patients who are on warfarin and aspirin, or your warfarin, a DOAC and aspirin, or warfarin and aspirin, without it's clearly just been that it got added on and the additional bleeding risk was sort of discounted. I think many of us are accustomed not to really considering a very high bleeding risk associated with aspirin on its own, but combining it with DOAC does, substantially increase the risk.
So there's another question in the box from one of our residents about, she must have a scenario here, a patient with a recent PCI just 3 weeks ago and atrial fib, and this patient needs an ultrasound guided biopsy for a thyroid mass. Would you hold warfarin DOAC?
I don't know what the risk is for the ultrasound guided biopsy for the thyroid mass, and if it could, so they'd be on, this is a patient who's going to be on an anticoagulant plus an antiplatelet agent. Yeah, I guess it's going to depend how urgent is the biopsy, and can we get them out of that highest risk period post PCI before stopping it?
Yeah, obviously common stuff that kind of comes back to family physicians, because they'll just punt it back to us and say, okay, well, stop coagulants, and we're like, well, wait.
Yeah, well, that's smart. That's a good catch, right? I had actually somebody today, we were changing his pacemaker, changing his defibrillator battery, and he was on warfarin. His CHAD score was 3, and I'd seen him a few weeks ago, told him, stay on your warfarin. This is low risk for bleeding. We even have trial evidence about what we're supposed to do in this situation. What's the safest course? Stay on your warfarin. But he'd been told so many times in the past to stop his warfarin for the operation. He forgot what we told him and he stopped it. His INR today is 1.5. And I would just say, well, okay, start it again today. We'll just get this done. And, because those are the times when they get a stroke, is when they've interrupted the anticoagulation.
Dr. Zwicker has noted that the thyroid biopsies is a fine needle aspirate. There is quite a long list of, in the anticoagulation guidelines, of procedures that can be done without interrupting anticoagulation. But I don't know if the people on the other end of those needles agree. And so often our radiologists or people who are doing these biopsies may not share that opinion. So it's obviously worth a discussion before the patient's on the table.
Yeah, we sometimes get the same questions from dentists who they're going to pull out some teeth or something and they want to, stop the anticoagulant. So, well, how soon do those teeth really need to come out? Can we get through this highest risk period? And yeah.
So another question about, do you consider kind of intermittent atrial flutter equivalent to atrial fib as far as anticoagulating the patient?
Yeah, that's a terrific question. And the answer is the truth is that they're not equivalent. The risk from atrial flutter is probably lower. There's less atrial myocardial stunning from flutter than there is from fibrillation. However, they're considered the same for the purposes of guidelines and determining what to do. And part of that is because that many, many patients who have atrial flutter also have atrial fibrillation. It's often silent. And so the sort of collective wisdom, and this is around the world, is that we treat them the same, even though we know that the statistical comparison is probably a little bit different. And similarly, paroxysmal is probably lower risk than persistent. It has to be, but again, that's very unquantified, and so they're treated the same.
We had a question, John, about lowering the dose of ticagrelor when used with an oral anticoagulant. GI dosing normally, of course, post-stent.
Yeah, I think it's the normal dose. The one that's reduced is the one dose that's reduced is rivaroxaban. The standard dose is 15, and I think that's just because it was in one of the trials, whereas it's standard dosing for all of the others that are recommended.
In fact, the rivaroxaban combination drug also, it was 15 with the clopidogrel. Yeah. And if your GFR is less than 50, it actually was a 10 milligram dose.
That's right.
Lower.
Yeah.
So they again even renally adjust beyond that. So
that's right.
Worth engaging your pharmacist for these challenging cases.
I see there's some questions in. Stephanie, I'll let you moderate the questions, I guess.
Yeah, so there was one about oracle ablation to reduce risk of stroke and atrial fib.
Oral anticoagulation. Sorry, what was the question?
Where are we with oracle ablation to reduce the risk of stroke and atrial fib?
Right, okay.
Yes.
Sorry, Paul, you cut out there.
I expect that's probably for appendage ablation, is it?
Yeah, I think that is what's intended. So as you may know, we have brand new exciting data on this. Not much new from the left atrial appendage closure device data, which is fairly kind of disappointing. There's a procedural risk that may not dramatically outweigh the reduction in stroke from the device, and sort of disappointing results from the trials. But we do have brand new data on surgical resection of the left atrial appendage. JF, who's on the panel, was one of the investigators on the trial. And the trial just published recently showed a significant reduction over and above the use of anticoagulation in doing a left atrial appendectomy at the time of cardiac surgery if the patient had a history of atrial fib and an elevated CHADS VASC score.
So we'll have to ask our surgical colleagues if this is now being widely adopted, but certainly a great opportunity.
Yeah, I think so. If I comment, you know, I just saw a patient for tomorrow for surgery with paroxysmal AFib for aortic valve, and now with the trial evidence, I can't imagine I wouldn't take it out. So it's pretty hard not to.
Yeah.
Yep. Sorry, I didn't mean to jump in.
No, it's good.
Added value, that's what we're looking for, JF, that's great. All right. Well, obviously lots of challenges remain with these patients. It's the yin and yang of anticoagulation versus bleeding, but we really appreciate your comments and talk. John, that's a great review, and we'll know who to call when we have more trouble in the future.